So it's a great pleasure to have Dr. Abdul Basit, who is a professor of medicine and director of the Baqai Institute of Diabetology and Endocrinology in Karachi, Pakistan. He is a leading expert in the area of diabetes, and he is the president of the International Diabetes Federation for the year of 2014-2015. I had the pleasure of meeting with him in Dallas last year, and it's a great pleasure to have him today to talk about diabetic foot and his perspective from Southeast Asia. Take it on, Dr. Abdul Basit. It's a great pleasure to have you today.
Right. Thank you, Subhash, for your kind introduction. Good morning, colleagues in Dallas and the United States. My topic of today is diabetic foot, and what I thought, knowing that major part of the audience are cardiologists or affiliated more with the cardiology faculty, so I thought the first thing we shall do is to let you have a feel of the history of diabetic foot in Pakistan, and hence I subtitled it as From Stone Age to Space, because I have a feeling that majority of you would be wondering why we are entering into diabetic foot and what's so special about Baqai Institute of Diabetology and Endocrinology, which is BIDE, and what's so special about diabetic foot in Pakistan. So this is how what I found old Stone Age was, man of skills using rocks, a stool, or fire generated in the good early days. So diabetic foot, highly mortal condition, and that's why we are so obsessed about it. 70% of people who undergo lower extremity amputation die within 5 years of amputation. Lower extremity amputation will be referred in my future slides as LEA, L-E-A, LEA. And if you see through the slide, then prostatic cancer, Hodgkin's disease, breast cancer, colorectal, so amputation is comparative with all these malignancies, highly mortal condition. Every 20 seconds, a limb is being lost in the world. So unfortunate. So if I talk for good 30 minutes, we expect 90 amputations related to diabetes taking place in that half an hour. As we discussed, 5 years after LEA, 70% people may have died, so it's a high amputation rate. And up to 85% of all amputations are preceded by an ulcer, i.e. they are preventable. Coming to Pakistan then, 19 years ago when we came to Pakistan after being trained in the UK, we had no specialized diabetic foot clinic. No specialized foot clinic. At present, we have around 7 million diabetics in Pakistan, 0.4 million people suffering with foot ulcers, and at the start we had no qualified podiatrists or diabetes educators. Nearly 40,000 legs are lost annually as a consequence of diabetes in Pakistan. The initial puzzle or dilemma was diabetic foot to be seen by a surgeon or a physician. And the patient used to ask, where shall I go? Whom shall I ask for help? And there were no trained diabetic foot care assistants. We analyzed in the initial phase about public awareness or patients' awareness for diabetic foot ulcers and diabetes per se. And the first paper we got published, we had 100% people unaware about diabetes complications whatsoever. The concept at that stage was look at the ulcer only. So it wasn't a holistic approach. People were targeted for glucose only. Dressings of all kinds were being used, and narrow spectrum antibiotics used to be prescribed only for 5 days. It may sound a bit ridiculous, but this is a fact that when I started the first foot clinic and saw patients like this one on the screen, He was told by our good surgical friends and colleagues, with due respect to them, that if you put pressure on these feet, the pus will flow out. So people were asked to walk on diabetic foot to get rid of the pus inside. Then came the next stage, a better stage, a new stone age, you can call it, leap forward, more of gratification. As the first diabetic foot clinic established in 1996, one gave the idea of 8 hours OPD, but at the same time for diabetic foot, we gave the idea that it's always to be treated as an emergency unless proved otherwise. So we gave a 24-hour phone service from day one. We entertained all walk-in patients from everywhere for diabetic foot. And this concept, to start with, was important. As I said, there were no specialized foot clinics by that time. So this is the first diabetic foot clinic. And as again to repeat, no qualified podiatrist. In 2003, we were able to move to new premises. By that time, had chance to send our colleagues for short trainings abroad. Worth mentioning is Dr. Zahid, who now takes care of our foot-related developments on the platform of Pakistan Working Group on Diabetic Foot. Also worth mentioning is Dr. Asim bin Zafar, who is sitting next to me, will be looking after and coordinating with you and the group for XLPAD. We started training our own diabetic foot care assistants. We educated that we cannot afford highly trained podiatrists, at least at the start of the foot services. So we started training of our diabetic foot care assistants. We got our initial publication about presentation and outcome of diabetic foot published. And in 6 to 7 years, we had this amputation rate of around 27%. In 2006, then we had an international diabetes conference in Pakistan. We established this Pakistan Working Group on Diabetic Foot. Most of you, if you had a chance to know international people, leading people in diabetic foot, one is Carol Becker from Netherlands, one is Andrew Bolton from UK, Mark McGill is Vice President IDF, leading diabetes education internationally. And so we had a cluster of colleagues from abroad. We, by that time, started to give the concept that instead of looking at the ulcer, we shall look at the feet, and in fact, both feet, that means, and not only at the ulcer or the ulcerated foot. We had this liberty or blessing of having handheld Dopplers being used in our clinics. And we gave the concept that metabolic control is important rather than only the glucose. So included blood pressure, improving the lipid profile, antiplatelet therapy, and asking for cessation of smoking. We developed low-cost dressings. So all kinds of specialized dressings or the expensive one were abandoned in general, and only simple stuff like pyridine or Usol, which we make in our own pharmacy, train others to develop it for desloughing wound, that was educated. Broad-spectrum antibiotics were used and taught that they shall be used with higher dosages, longer duration. You would appreciate that one of the main issues in these parts of the world are infections and all kinds of infections, and for longer durations for multiple reasons. To treat infections aggressively was educated. We developed our own offloading devices. These people, you can appreciate, between the ages of 40 to 60, usually if they are advised bed rest for 6 weeks to 8 weeks, it's nearly impossible or practically doesn't work. So we developed our own offloading devices which were very cost effective. So say these ulcers which were taking ages to heal got these kind of special footwears and the ulcer heals in 6 to 8 weeks. These data have been published and these offloading devices have been widely accepted for use in the developing world now. By this, we were able to decrease our amputation rate by around 75%. So if you remember, this figure initially was 27% plus, is now reduced by 75%. And this was published when we had a joint data share with William Jeffcott Group in United Kingdom and G. Abbas Group in Tanzania and Stephen Morbach Group in Germany. So next came the stage, bit more civilized, with more advanced technology and specialized workings. We started to say that one center or one institute having a good rate of treatment of foot ulcer and a decrease or reduction in amputation is not enough. We need to have a nationwide campaign. We were lucky to get funding from World Diabetes Foundation for a 3-year project. This was called a step-by-step project, was successful in India and Tanzania, and we were the third one to follow their footsteps. We started training teams pan-Pakistan. So we did a basic course for 199 teams all over Pakistan. When we say teams, it means not only the doctor, but his foot care assistant as well. So they jointly used to come and attend these courses in which they were taught the basis of foot care management and infections and simple tools, etc. After a year, we went back again to the same teams, got 178 teams trained, again pan-Pakistan with an advanced course in which we were talking about prosthesis, foot pressures, peripheral arterial disease, Charcot joints, etc. We gave the concept, which was not new in fact, because in Italy this has been practiced in the past, that we train physicians into simple diabetic foot surgeries, curtailing the cost of surgery and reducing the surgical load, and that also worked and was accepted internationally by International Working Group on Diabetic Foot, in fact widely acknowledged. And so we then have a 6-week course for diabetic foot care assistants. This again is now getting international recognition. In fact, in May we are going to have a full international curriculum design for such short course. By now we had trained 103 diabetic foot care assistants pan-Pakistan. And so we established diabetic foot clinics all over Pakistan. And lo and behold, by these clinics we were able to reduce the amputation rate by half, by 50% in these clinics. We then moved on to develop a National Association for Diabetes Educators of Pakistan, where not only doctors are part of it, but also podiatrists, foot care assistants, dietitians, educationists, specialists, nurses, pharmacists, including patients, philanthropists, key opinion leaders, media people, etc., to create awareness pan-Pakistan. We then had the honor of training people from Afghanistan by the collaboration of World Diabetes Foundation and to do such courses in Sri Lanka. In fact, a very similar course has only been done last week again in Sri Lanka, and now we are expecting their teams to come to us for a week's course. Moving on to recognition internationally, there is a meeting in Netherlands every 4 years. So 2007 we had it, and then 2011. This is a group what we call as a consensus group, which develops consensus guidelines for the management of diabetic foot internationally. and I had the honor to be there representing Pakistan and major part of the developing world with other colleagues in 2007 and 2011, and these are the guidelines then disseminated universally. And the concept was given that not only look at the ulcer or the feet, but look at the patient holistically, so to say. And final part of my talk is that we have started thinking of arterial Dopplers. I would, in the series of lectures to cover, will give data about how much of neuropathic feet we see and how much of neuroischemic feet we see. Pure ischemic ulcers are a reality. I would say if data isn't there to support me, but from anecdotes, or you can say the data which is like 10 years old, that pure ischemic ulcers we see less than 1%, 50% otherwise we see pure neuropathic ulcers, and around the same number of neuroischemic ulcers. So we have started taking interest into vascularity and the circulation per se. By interest, I mean that we were looking at pulses from the start, but now thinking of in terms of having effects or revascularization, estimating through arterial Dopplers, etc., and ending in true collaborations nationally and internationally in this regard. One of the cases just to share with you is like this management of ischemic or a neuroischemic foot post PTA, the good results, and with the fullness of time we will be able to share much more results with you in this regard. Final, delivering integrated care to prevent diabetic complications. We are part of a blindness prevention program in collaboration with Al Ibrahim Eye Trust and Diabetic Association of Pakistan, headed by Samat Shera Group, and Fred Hellos are very generously helping us out in this regard. We have a nephropathy prevention program with the collaboration of Kidney Foundation. We started joint cardiometabolic and peripheral arterial disease clinics, PAD clinics, in two leading institutes of Karachi. One is National Institute of Cardiovascular Disease, NICVD. The other is Tabba Heart. That was done in 2013. We have started educating antiplatelet therapies for foot circulations, vasodilators, ACE inhibitors, avoidance of beta blockers. We have moved to other dressings as well, apart from pyodine and usol, especially when we get resistant organisms, so acetic acid, sometimes silver dressings, etc. And now the concept is to prevent or to talk of prevention of ulcers in the first place. So we identify feet at risk. We have got our criteria developed into the software that when patients come to OPDs, as diabetic OPDs, they shall be looked at the feet, and there a feet at risk alarm bell should ring if the criteria is met. Foot care advice we start to give from day one. Our educators, they are seeing the patient day one, are advising regarding diet, lifestyle, etc., including foot care advice. We talk of this, that today's callus is tomorrow's ulcer. Custom-made footwear, we are not too much fancying it. We suggest that we shall be able to develop footwear manufacturing which shall be adaptable nationally, both cost-effective and both acceptable to the community. So I'll share only few slides about what we see our future in diabetic foot. One is that we need nationwide diabetic foot clinic network. We propose 1,700 such foot clinics to be established. We have already started working on 600 teams. Pen Pakistan this year, inshallah, will be training these 600 teams for basic course. The next year, they will be having the advanced course. I apologize, this is written by 2016, but it will be in fact by end of 2017 that we will have 1,700 teams trained in advanced and basic courses, Pen Pakistan. We are in the process of suggesting starting a full podiatry program. As you would have understood by now, that we in Pakistan, as in many other countries, are affording diabetic foot care assistance. But now a time has come when we shall go for specialized training of podiatrists, especially with this infrastructure set for the foot clinics. We had from 2013 started a full diabetic foot symposium, fully dedicated diabetic foot symposium. The first was in August 2013, the second was in August 2014, and now we are heading for an international diabetic foot conference in Karachi, inshallah 21st to 23rd of August 2015. By that time, we expect lot of publications and data nationally. We expect international faculty to collaborate with us, contribute and help us out in this conference. We may ask colleagues like Subhash and his team to be able to honor us with either their physical presence as well, or at least through webinars and teleconferencing to share their data. This year in May, we meet again after 4 years in The Hague, Netherlands, and this time I have the honor to be part of the advisory board member for the Diabetic Foot Conference, as I said, is being done every 4 years. And we have started now to talk about in the future for look at the community, and this is being part of it, an honor for us. I'm very grateful to Dr. Banerjee, Dr. Atif, and the colleagues to honor us, and it's a matter of pride for me, my institute, my country, that we be able to share our data regarding peripheral arterial disease and to be part of our registry. We are in the process of developing a type 1 registry. We have got collaborators, Pan Pakistan, and so hopefully this will be another step for better management, strategic planning of PAD in Pakistan. We have started linking 10 major teaching hospitals in Pakistan by the name of Advisory Board for the Care of Diabetes, ABCD. I have the pleasure to be chairman of it, and all these are 10 teaching hospitals from 10 big cities of Pakistan. This is Lahore, this is Islamabad, the capital, Sakkar, Abbottabad, Bahawalpur, Kashmir, Mirpur, Multan, Peshawar and Quetta. For those of you who have some interest in geography of our country, these are 10 major cities of Pakistan, and what we are linking is digitally linking 24/7, 365 days a year through the cloud technology. And we have started with diabetic foot clinic to start with every Wednesday morning, Pakistan 9 a.m. time. By the end of the year, we expect all 10 units to be linked. At present, we are 3 who are linked together, share our patients and data, and learn from each other experiences. So in summary, from old Stone Age, no foot clinic, to the concept of first foot clinic and then 115 and future 1700, from the dilemma of whether it's a surgical or a physician's entity, to training doctors, to training teams, to now going to advisory board for the care of diabetes and a national health network with no foot care assistants to have training and then trained, and now planning for masters in podiatry, awareness of patients, then awareness through a national forum, then having consensus meetings internationally and part of the international advisory board. To develop from a concept or start from a concept of look at the ulcer, then the feet, then the patient, now talking of the community, pulses evaluation, handheld Doppler, now international PAD registry as part of the development, metabolic control, dressings to simple dressings, and now developing customized, specialized dressings, antibiotics being sorted out, corrective surgeries we are educating, footwear manufacturing and insoles development we are heading towards in future. We are talking about not only prevent deaths or amputations, but ulcers, and now we are embarking on a nationwide Stop Diabetes in Pakistan, i.e. prevent diabetes. With this, I'd like to thank my international collaborators who help us out and the national collaborators, and I thank you all for your attention, and I'm very grateful that you gave me a chance and an honor, and hopefully be able to take the question answers if there are any. Thank you.
Thank you, Dr. Abdul Basit. This is an exciting journey, and I've had a chance to listen to you before. And this is unbelievable organization. So I would like, before we go into the Q&A, for you to maybe acknowledge some of your key colleagues from your city or other places in Pakistan that have helped you put together this exciting program. This is unbelievable. And each time I come across this data, I think this is something that many countries and many other places in the world can emulate. So thank you for sharing your insight and the stepwise journey through this process.
Thanks, Subhash. I'm very grateful. It may be that I sounded too much of blowing my own trumpet during the lecture, but I was trying to put Pakistan's diabetic foot status in perspective, and I am grateful, or my colleagues are grateful to people like you and others who not only appreciate us, but at the same time fully support us and endorse in our activities. So we are very grateful to you.
That's fantastic. I think you should blow your horns, because this is a kind of organization and a grounds-up process that I think you and your colleagues should be very proud of. The question I have for you is that, most of us, our work is in the area of endovascular intervention and revascularization. So what are your current guidelines or guidance to your providers in the diabetic foot clinics, or in general to physicians and primary care specialists in Pakistan to actually refer patients, and what is the process, and how do these patients actually get to endovascular revascularization, or even surgical revascularization for that matter?
Right. Firstly, if you would appreciate, when we met, we discussed this, and today also, that unfortunately, the nationwide network, when we say, means a fully private or only very partially having a public sector involvement, as like the Advisory Board for Care of Diabetes, but usually they are all private setups. Now, they are linked with us one way or the other. I would say that don't take it that all the 115 clinics at present are 100% linked with us, but at the same time, I can safely say that majority of them, one way or the other, follow our guidelines and protocols. So this was to start with. Good to know that we do have an infrastructure developing and coming up further. Now, as regards your question, how do we guide them, or what are the guidelines for them to refer to for endovascular procedures? The answer is that we ask them to refer such cases of diabetic foot which are not treatable at the start, or having like no pulses or very minimal ABIs, to the secondary and the tertiary care center. I could not show you the slide in which there is a referral system. We are in the process of developing a full document of primary care, secondary and tertiary care referral system, which we call as National Health Network for Diabetes. Once it is in black and white, I can share the document with you. At present, all the primary care physicians running the foot clinics are advised to refer the patient to secondary care if, number one, the patient is toxic and needing hospital admission, etc. Number two, it's a chronic non-healing ulcer taken as neuropathic and being treated for a while and not responding to the conservative management for 4 to 6 weeks. And number three is gross ischemia documented may it be pure ischemia, may it be neuroischemia, in that case to refer to secondary or tertiary care.
Well, that's great. I think I was saying that, we have been involved with endovascular revascularization for a sufficient long period, so we were offering our help and insight that if your societies would develop a particular revascularization and strategy document, we'll be happy to participate and lend our input into it if the need ever arises. So please take that offer, and we'll be happy to help.
That is Subhash, what the main aim of what you can call as joining hands is, that we come up with policies or development of guidelines or strategic planning through specialized centers worldwide. And as I kept pointing out quite a few times during my presentation, we are very much part of international working group on diabetic foot, and for PhD taking your expertise and taking the volumes of the work you have got. It will be an honor and a privilege to have the guidance from you when time comes.
Thank you very much. One last question from me, unless anyone else has, is that, in the United States, as you rightly pointed out at the beginning, that most patients with diabetic foot actually die of cardiovascular disease or myocardial infarctions. So are there any approaches for secondary prevention, for example, simple measures I can understand in Pakistan, like antiplatelet therapy, aspirin therapy, and other awareness of medical options that would lower cardiovascular death in these patients?
Yeah, very good question. What we are doing now is educating through CMEs and courses pan-Pakistan to the doctors. Number one, that make sure each of their patients is on stuff like metformin and an aspirin and a statin and an ACE inhibitor, unless contraindicated or not desperately indicated. So we say that they shall be on it, or you shall think of it 100 times for not putting somebody on it. Now, on the other hand, we are taking another strategy, is that through public awareness programs and through media also having a campaign that certain medicines ought to be there on board for each diabetic, and there shall be good reasons for these medicines not being prescribed to the patient. One of them is aspirin, one is a statin, one is metformin, one is ACE inhibitor. And again, a policy document for management of type 2 diabetes guidelines are underway by a society which is called Pakistan Endocrine Society. We are very much part of it as well. That society is busy, and hopefully in the next 3 to 4 months will come up with a guidelines document for management of type 2 diabetes, including all these strategies.
Thank you very much for that answer. Thank you very much. I'd like to invite anyone else, if they have any text or audio questions, please feel free to ask them. If not, Dr. Basit, Abdul Basit, if there are any additional questions that come on through the chat lines or personally asked through in writing, I will try to forward them to you through Atif and get an answer from you. Right. I really appreciate your time and the effort of putting together this presentation and sharing your insight of putting together this wonderful system of diabetic foot care in Pakistan, and I think a system that could be replicated, as I've said before, in many other Asian countries, including Sri Lanka, India, Bangladesh, and other countries. So I am very delighted to have you today, and I appreciate your time and input, and I look forward to closely collaborating with you and your organizations in the years to come.